In this workshop, we're going to present few hemodynamic case studies, and we will utilize the Transpulmonary Thermodilution method. We'll get parameters that will be analyzed to make management decisions. And I would like first to present these 3 chest x-rays for 3 patients who are hypotensive. And the question is, can we give more IV fluid to these patients? If you take a look on the x-ray in the middle here, you will see bilateral pulmonary infiltrates. You would be very much concerned of further worsening of his pulmonary edema if you give more fluid. On the left side, you will see bilateral pulmonary infiltrates would be consistent with ARDS, but since this patient is hypotensive, you say maybe I can give this patient fluid. The patient on the right side, you see right middle lobe, right lower lobe infiltrate, possible left retrocardiac, is hypotensive, I may give him fluid. Well, what if you know that the extravascular lung water index for this patient is 21 compared to this patient with the extravascular lung water index of 11, and this patient is having the extravascular lung water index of 5. Well, your decision is going to be completely different. Now, the patient on the left, you are definitely not going to give him any further fluid. The patient in the middle may or may not. We like to see extravascular lung water index less than 10, but you can put into consideration other parameters and decide whether this patient may benefit from fluid or not. And the patient on the right side will definitely be given fluid. Is hypotensive, his extravascular lung water index is appropriate, and he can benefit from further fluid. Well, you need to put in mind the parameters that determine the blood pressure. The blood pressure is the product of cardiac output and systemic vascular resistance. Then the cardiac output is determined by the heart rate and the stroke volume. The determinants of stroke volume are preload, contractility, and afterload. So in any hemodynamic monitoring device, we would be looking to have parameters that give me an information to know what's the preload, what is the contractility, what's the afterload by looking at the systemic vascular resistance, and what is the stroke volume. In the formula that we all know about the mean arterial pressure, it is the heart rate multiplied by the stroke volume, which is the cardiac output, multiplied by systemic vascular resistance, of course, plus central venous pressure. And causes of low blood pressure would be either caused by decreased preload, decreased contractility, or increased afterload, such as pulmonary embolism, or pericardial effusion. It can also be caused by abnormalities in the heart rate with tachyarrhythmias or bradycardias. It can be caused by decreased systemic vascular resistance with vasodilatation, and it could be also caused by decreased compensatory mechanism with problems in the autonomic system. So the clinical condition for this abnormalities would be hypovolemic with the preload, cardiogenic with a decreased contractility, obstructive with increased afterload, distributive shock with vasodilatation, cardiogenic with any arrhythmias or bradycardia, and neurogenic with the decreased compensatory mechanisms. The indications for advanced hemodynamic monitoring are limited actually to those patients who are in shock and have evidence of ARDS. In those patients, we would like to have more advanced hemodynamic monitoring system, where we can get more information that can help us in managing those patients. Typically, those patients would benefit from transpulmonary thermodilution devices. We can do pulmonary artery catheterization. We rarely do that now for those indications, since we get enough information that we need from either the TPTD or the LITCO devices. Also, those patients who are in shock and you initiated management, resuscitation with fluid vasopressors and are not improving, those patients, you may get more information through these devices where you can alter your management to these patients. Probably the only indication for pulmonary artery catheterization is a shock syndrome that is associated with right ventricular failure. The information that you get from Swan-Ganz catheterization is probably more than what you get from transpulmonary thermodilution. And if your patient is in shock, but you initiated resuscitative measures and the patient is improving, there is no need for advanced hemodynamic monitoring device. So just to remind you, with the Pico system or the transpulmonary thermodilution method, let's just watch this video.
In order to use Pico, a dedicated catheter is needed, which can be inserted into the brachial, axillary, or femoral artery. In addition, a standard central venous catheter is required. For the transpulmonary thermodilution, pre-cooled saline is injected into the central venous catheter. The temperature and the starting time are recognized by the pulsioflex monitor. The indicator passes the right heart, the lungs, the left heart, and finally the Pico catheter, which allows, because of an integrated sensor, a specific temperature curve to be recorded. From this temperature curve, very precise parameters can be derived as cardiac output, global end diastolic volume, and extravascular lung water.
So, in addition to these parameters, you can get other information from the pulse contour analysis. You can get information about the contractility by looking at the peak pressure and the increase in the stroke. You can get information about the stroke volume by looking at the area under the curve from the beginning of the stroke till the diacritic notch. You can get information about the aortic compliance by looking at the descending part of the decrease in the pressure from the peak to the diacritic notch. And finally, you can get information about the vascular tone by looking at the decrease in the pressure from the diacritic notch all the way to the diastolic pressure. And with the thermodilution method, you get parameters that include the intrathoracic thermal volume. That is the volume of all the components, starting from the right atrium, right ventricle, pulmonary circulation, lungs, all the way back to the left atrium and left ventricle. So this is everything, the whole intrathoracic thermal volume. Now, you can get information by looking at that dilution curve. You can get information about pulmonary thermal volume. And if you get the pulmonary thermal volume, you can subtract this from the intrathoracic thermal volume. You end up having the global end diastolic volume, which includes the right atrium, right ventricle, left atrium, and left ventricle. Now, if you multiply this by 1.25, you add the pulmonary circulation to it, and this is what we call the intrathoracic blood volume. Now, if we have the intrathoracic blood volume, this is all the blood areas, and we have the intrathoracic thermal volume, that everything, including the lungs, we can easily subtract the intrathoracic blood volume from the intrathoracic thermal volume, and we are left with only the lungs. This is what we call the extravascular lung water. This is a screen that you get when you hook this device, calibrated and zeroed, and then you get these parameters that would include different parameters for the hemodynamic profile. We'll start with the preload parameters. We can look at the global end diastolic index as a value of less than 700 or more than 700. The normal value is between 680 and 800, but anything less than 700 would probably indicate that your preload is decreased. Then you can look at the stroke volume index, and you know that the preload is determinant of how strongly the patient is going to contract, and this is based on the Frank-Sterling curve. And the third component, and the stroke volume index value, is between 33 and 47, the normal value. And the third component would be the stroke volume variation. Make sure that your patient is on 8 ml per kg of tidal volume before you look at the stroke volume variation. And anything less than 10 to 15 may indicate that your patient is not fluid responsive. Anything higher than this value may indicate that your patient may benefit from fluid. The second parameters that you get are parameters for contractility. And clearly, you can get first the stroke volume index, and you can get information about the global ejection fraction. The normal value for this is 25 to 35%. This is different than the left ventricular ejection fraction that you know. And then you get information about the cardiac index with a normal value of 2.5 to 4 liters per minute per square meter. Parameters for afterload would include only the systemic vascular resistance index, and the normal value is 1970 up to 2390. Then you can get the information about the extravascular lung water that we described. You can get the index. That normal value of this index is between 3 and 7. You like to have it below 10 all the time. And the last parameter you would get is the permeability index that will be able to differentiate whether your pulmonary edema is caused by ARDS versus cardiogenic edema. The company presents to you this algorithm that can be utilized to guide you through different interventions they can do on your patient based on the hemodynamic profile. So it doesn't include everything, but it's nice to go through it and see how it is organized. So first you look at the cardiac index. If you determine that the cardiac index is decreased, less than 3, then you have problem with the contractility. You look at the preload. Are we dealing with decreased preload? If the global end diastolic index is less than 700, that means that the preload is decreased. Before you give fluid to the patient, you want to know the extravascular lung water index. If that index is less than 10, you can safely give the patient fluid. If it is more than 10, you can be cautious in giving the fluid to the patient, and you can add catecholamines to your patient's management plan. If the global end diastolic index is more than 700, that means that your preload is not decreased. So there is decreased contractility without decreased preload. So what about the extravascular lung water index? If it is more than 20, your patient is clearly in pulmonary edema. With his hypotension, I would try to do fluid offloading and may use catecholamines at the same time. But if the the water index is less than 10, at that time, you don't need to remove fluid, but you would use catecholamines. So let's go to the left side. What if the cardiac index is more than 3? Well, again, let's look at the preload. Global end diastolic index. Is it less than 700? So if it is less than 700, I may have a decrease in the preload, or at least it's not increased. Then I look at the extravascular lung water index. If that index is more than 10, at that time, I may do fluid offloading. If it is less than 10, you would observe and may or may not decide about vasopressors. Similarly, if the global end diastolic index is more than 700, at that time, with extravascular lung water index of more than 10, you would do fluid offloading. And less than 10, you would just observe and see how other parameters are put together. With this background, I would like to present the first case. 67-year-old diabetic patient with history of hypertension. He presents with cough and fever for 3 days associated with Rikers. He was diagnosed to have community-acquired pneumonia. In the emergency room, blood pressure was 100/50, respiratory rate is 30, saturation is 92% on room air. We have ABGs with pH 7.30, PCO2 of 40, PO2 of 60 on room air, and lactic acid of 4. So the lactic acid is increased. There's no decrease in the blood pressure. However, this patient is hypertensive in his past history. So let's take a look on the chest X-ray, right upper lobe infiltrate. Resuscitation was started for this patient. Respiratory sample and blood cultures have been obtained, including atypical screen. He was started on high-flow nasal cannula in addition to antibiotics. The question, would you give more fluid? The answer is clearly yes. And most likely, he would use balanced fluid crystalloid that is better than normal saline, according to some studies. The verdict is not out yet, but probably the benefit of balanced fluid crystalloids is out there that can be justified given to patients with resuscitation. The question of when to stop fluid resuscitation or fluid administration is difficult to judge without invasive monitoring data. This patient developed or deteriorated and he got intubated. Now it is sedated on mechanical ventilation. FiO2 is 70%, PEEP of 8, tidal volume of 6 ml. Blood pressure is 110/50, is now on levofed of 0.3 mics per kg per minute, and the lactic acid increased to 5. So clearly, this patient is indicated for advanced hemodynamic monitoring. This patient has shock. In addition, he progressed into ARDS. So he would benefit from thermo or transpulmonary thermodilution monitoring device. So the Pico device was inserted. We have the EV1000 volume view here, and those are the parameters that we obtained on this patient. So I'm going to analyze this slowly, and then we're going to see what happens if you do any of these interventions or measures. So in terms of evaluation, as I stated earlier, we would start evaluating the preload first. And if we take a look on the global end diastolic index, it is less than 700. 483. Now combined with stroke volume index of 26, which is decreased, normal is 33 to 47. In addition to stroke volume variation of 16%, despite the fact that this patient is on 6 ml per kg of tidal volume on mechanical ventilation. If you increase the tidal volume to 8 ml, you're probably going to see higher stroke volume variation. So these three indicators or three parameters indicate that this patient has decreased preload, and probably he would benefit from fluid bolus. However, before we do that, let's just assess the other parameters. The second thing I would assess is the contractility. And the contractility is assessed by the global ejection fraction. So you can see that his global ejection fraction is 21%. The normal is 25 to 35%. So it is slightly decreased, and most likely because of his preload that is decreased. Again, the stroke volume index is decreased, and take a look on the cardiac index, it is normal. His heart rate is on the higher side, that's why his cardiac index is normal. So yes, we have decreased global ejection fraction and stroke index, stroke volume index, but the cardiac index, and you can see here the cardiac output are acceptable. So in other words, I don't think I would benefit much from giving this patient inotropic support. You can see that we have an option of dobutamine. We'll see what happens we give that if we do this intervention. The third thing that I would do is assess his afterload or systemic vascular resistance. The index is 1490, which is decreased. The normal is the lowest or the minimum number of the SVRI is 1970. So this indicates that we have a syndrome that is causing vasodilatation. Most likely this patient is septic with decreased preload that he needs fluid for. But let's just, before we give him fluid, let's look at the extravascular lung water index. It is 10.8, and as I stated before, we like to keep it below 10. Otherwise, we will see worsening in the extravascular lung water for this patient and predisposing the patient for the effects of pulmonary edema. The last thing that I would look at is the permeability index, which is 2.5, indicating that we're not actually seeing ARDS here, even with a slight increase in the extravascular lung water index. So we are clearly, here we have 5 different interventions, and we can clearly say that this patient certainly does not need fluid off. Somebody, for any reason, because of the extravascular lung water index, decided to give this patient a dose of Lasix. His mean arterial pressure is 66, so he said, well, this patient can't tolerate Lasix, and ended up giving this patient a dose of Lasix. This is what will happen. You're going to worsen his preload numbers, and you can see here the stroke volume now is 19. The stroke volume index is still decreased, and the global end diastolic index is decreased. Look at the contractility, it got worse. The global ejection fraction is now 19%. You took off more fluid, you stimulated the autonomic system more, and the patient ended up with increased systemic vascular resistance. Since you took off some fluid, you improved the extravascular water index. However, you worsened other hemodynamic parameters. The permeability index did not change. So I think giving fluid was a wrong decision for this patient, and let's just go back. At the same time, here you can look at the perfusion parameters. So by giving Lasix, the lactic acid went up to 6. Yes, you did improve the FiO2, went down to 50%. However, you worsened his perfusion to the organs, and that's what you want to avoid. So let's go back to the baseline, and let's decide on giving a vasopressor for this patient. Somebody says, well, since I see the systemic vascular resistance here is decreased, I'm going to give this patient a vasopressor. If you give this patient a vasopressor, take a look on what happened. Yes, you constricted the alpha-1 receptors and you caused the systemic vascular resistance to go up. You still have decreased global end-diastolic index. The stroke volume is still decreased. The normal is 33 to 47. Take a look on the stroke volume variation. It's clearly indicating that your patient needs fluid. With vasopressors, you probably slightly improved the ejection fraction and you improved the extravascular lung water. However, look at the lactic acid. Went up to 5.5. The skin is mottled and the patient has low urine output. So that was a wrong decision that you're giving your patient. So let's go back to case 1. Well, I kept saying that this patient is having decreased preload and he would benefit from fluid. However, my only concern would be that his extravascular lung water is above 10. So let's see what happens if we give this patient a fluid bolus of 4 ml per kg. Well, we improved his preload. Stroke volume variation now is 6. We improved his stroke index. Stroke volume index is up to 25. The global end-diastolic index slightly improved to 492. Global ejection fraction, what was it before? Was 21, still 21, no changes. Heart rate increased. Cardiac index slightly increased from 2.7 to 2.9. And the systemic vascular resistance slightly increased. So by giving the patient volume, we improved his preload. Take a look on what happened to the extravascular lung water index. It was 10.8, increased to 11.4. The FiO2 went up to 90%, indicating more water in the lungs. And unfortunately, the patient's lactic acid was increased up to 4.5. Well, somebody would say, let's give him another fluid bolus. And if we give another fluid bolus, take a look on the extravascular lung water index. Went up to 19. The patient is most likely on 100%. And now the permeability index is clearly indicating that this patient is in ARDS. You can see value more than 3 now. Now the last option is to just go back to the baseline. If you give this patient dobutamine, what happens? Well, the global ejection fraction is increased to 24%. We increased the cardiac index. The mean arterial pressure did not change much. You would expect with the dobutamine that the SVR is going to go down, and it did. You can see the SVRI is decreased. However, the increase in the stroke volume for this patient, combined with the increase in the heart rate, increased his cardiac index. Okay. For whatever reason here, the stroke volume variation is improved to 9. But what I would say is probably the best for this patient would have been a fluid bolus to improve his preload and initiating dobutamine to improve the cardiac functions. At the same time, you need to monitor his extravascular lung water. Notice that with dopamine, we improved the extravascular lung water because of the improvement in the cardiac output. So with this, we can go to the second case. This patient is a 40-year-old man with history of hyperlipidemia. He came in with abdominal pain and found to have severe pancreatitis. His heart rate is slightly high, 120. Blood pressure 100/40, but his lactic acid is 4. Patient is hypoxemic with ARDS picture. He got intubated and mechanically ventilated. He's on 50% FiO2, PEEP of 10, tidal volume of 6 ml per kg. He already received 1 liter of sodium chloride, and clearly he's indicated for transpulmonary thermodilution monitoring because of his shock and ARDS. Those are his numbers. So again, when you analyze this, you start with the preload. In order to know the preload, you look at the global end diastolic index, which is decreased. Stroke volume is decreased. Now, the stroke volume variation is not elevated, but remember this patient is on 6 ml per kg of tidal volume on the ventilator. So let's go up to 8 so we can actually get an accurate number. So here we went up to 8 ml per kg on the tidal volume. Now we got stroke volume variation of 17%. So clearly this patient is having preload problem. The preload is decreased. Then you assess the contractility. The global ejection fraction is 27%, so it is with normal limits. At the same time, his stroke volume index is slightly decreased, but the cardiac index is normal or slightly elevated. The cardiac index is 5. His mean arterial pressure is 60 millimeter mercury. Now looking at the afterload, his systemic vascular resistance index is decreased. So we have distributive parameters, distributive shock in a patient with lactic acidosis, of course, decreased preload, and cardiac function is maintained at higher limits or slightly increased cardiac index. So now let's take a look on the extravascular lung water. It is 7. So meaning that, well, this patient can tolerate given fluid. And the permeability index is 2.7. We're fine at this point. So what are we going to do? Clearly that this patient needs fluid bolus. So if we give fluid bolus of 4 ml per kg for this patient, notice that slightly improved global end diastolic index, improved stroke volume variation. We have good cardiac functions, global ejection fraction is 25%, cardiac index 4.5, the mean arterial pressure now is 63. After load, we still have decreased systemic vascular resistance. We did not affect, by giving this fluid, we did not affect the extravascular lung water much, still acceptable below 10, and the permeability is acceptable. In terms of perfusion, take a look on the lactic acid, it is down to 2.5. So I think the patient benefited from the fluid bolus. So if we go to the baseline again, what if someone has decided to give this patient diuretics for whatever reason? Well, you're going to worsen his stroke volume variation, you're going to decrease the global end diastolic index, decrease the stroke volume. And the cardiac index now is less, global ejection fraction not much changed, the SVRI is increased. Water index in the lung is slightly decreased because you de-risk the patient, but his mean arterial pressure is decreased, and his lactic acid is increased. So it is a wrong decision to give this patient, and this is clear to everyone that there is no need for diuretics here. So let's go back to the baseline. What if someone decided to give this patient vasopressors? You would say that, well, his mean arterial pressure is 60. We have low SVR, and this patient may benefit from vasopressors. So yes, if you give vasopressor to this patient, you're going to improve his mean arterial pressure. You're going to improve his systemic vascular resistance. However, you're not actually giving him what he needs in terms of perfusion. His cardiac index is decreased, so probably the patient was given neosynephrine. Heart rate did not go up much or stayed the same. So the answer would be not to give this patient vasopressor alone. What this patient needs is fluid bolus. So let's go back to the baseline. And if we give this patient dobutamine, you're going to see that you're going to improve the global ejection fraction. You're not touching on the preload at all. Okay. Lung water did not change, but dobutamine is beta 1 and beta 2 stimulator. With beta 2 stimulation, you decrease the systemic vascular resistance further, and you decrease the mean arterial pressure despite increased cardiac index. And you can see the heart rate is increased remarkably. So for this patient, the appropriate management is to give fluid bolus and plus minus vasopressor support. And if you choose vasopressor, it would be norepinephrine. You can start both at the same time. You can give a fluid bolus and norepinephrine for this patient. Case number 3 is a case from the operating room, and this is in regard to hyperthermic intraperitoneal chemotherapy surgery. This surgery is designed for intraperitoneal cancers that are disseminated inside the peritoneum. It's based on giving heated chemotherapy that is poured into the patient's abdominal cavity. This would be done after excision of the cancerous tissues. We have 56-year-old male, history of hypertension but controlled, ischemic heart disease with 3 stents 5 years ago. Cardiac echo showed diastolic dysfunction. Ejection fraction is 48%. No valvular lesions. Normal pulmonary pressures. Hypec for colorectal carcinoma with metastasis to the peritoneum, omentum, and liver. Of course, the patient is going to be undergoing the procedure for long hours. Within 2 hours after the start of the procedure, the blood pressure was 100 over 72. Typically, those patients would have transpulmonary thermodilution method or an invasive hemodynamic monitoring method. And the main effect of the heated chemotherapy would be vasodilatation. So you're going to see that those patients have vasodilatation indicated by the decreased systemic vascular resistance. So this is only 2 hours after the start of the procedure. And we have these parameters. So take a look here. First, we assess the preload. Now, I keep doing the same thing and assess everything so I don't miss anything when I read the hemodynamics. So first, the preload. Global ejection, global end diastolic index is decreased. The stroke volume index is not the normal, starts at 33, so it's not much changed here. The stroke volume variation is 14%. Make sure that this is done at 8 ml per kg. So he may benefit from fluid. Let's take a look on the global ejection fraction. The normal of global ejection fraction is 25% to 35%, slightly lower. This is contractility. Stroke volume index, acceptable. Cardiac index, acceptable. So no issues with contractility. Let's move to the afterload. As I stated, the heated chemotherapy can cause vasodilatation, but the normal starts from 1970, slightly decreased, acceptable. Well, what about the extravascular lung water index? It is 7, acceptable. Anything between 3 to 7 is fine, less than 10 is okay. And finally, the permeability index is 2. So now take a look here on CVP is 5. So that's another preload indicator, a static indicator. But if you put the CVP with the global end diastolic index and the stroke volume variation, what you would do next is give this patient fluid. So this patient is underfilled and his preload is decreased and he will benefit from fluid bolus. So 5 hours later, we have global end diastolic index after the fluid is 800. Stroke volume index is acceptable. Stroke volume variation 9%. So we're fine with the preload. What about contractility? 24% did not change much. Good stroke volume, good cardiac index. So we're okay with the contractility. What about the afterload? It's decreasing, 1300, with a mean arterial pressure now of 59. So this patient is becoming hypotensive. So at the same time, we have extravascular lung water of 9, so we're still fine, and the permeability index is 2. So clearly this patient will not need any further volume, just maintain some volume for him. Contractility is okay, however, we may need to vasoconstrict him a bit with vasopressors. So this patient is vasodilated and norepinephrine was started. You would increase the dose if norepinephrine is already started. So now after starting norepinephrine, and this is midway through the chemotherapy phase, blood pressure now is 85/40 with mean arterial pressure of 48. Again, preload, global end diastolic index above 700, stroke volume variation 6%, stroke volume index is 67. So we don't have preload problem. Okay. What happens to the contractility? Global ejection fraction is decreased and cardiac index is decreased. Heart rate is 79. So we have contractility issue here. At the same time, take a look on the systemic vascular resistance is 1400. It is decreased. However, extravascular lung water is 10. It's at the border. As I said, we accept anything less than 10. We don't have major problem with the lung water at this point. And the permeability index is slightly elevated, 3.1. So I'm concerned about starting an increased extravascular lung water with increased permeability for this patient. But the main issue here that his contractility is decreased, and this is what I'm going to focus on. So what you're going to do for this patient with decreased contractility, clearly this patient would need an inotrope. So you started the patient on epinephrine. Why you did not start the patient on dobutamine? Well, with dobutamine, we're going to worsen his systemic vascular resistance, and we may cause further decrease in the mean arterial pressure. So we chose something that have beta-1 activity in addition to the alpha-1 on the vasculature. So the systemic vascular resistance increased. We increased the heart rate here, as you see. We increased the cardiac index, and the global ejection fraction is increased, and we improved his hemodynamics. Now, 10 hours since the induction, before closure, this is the parameters that you have. The surgeon is happy about the job and asks you if you can extubate the patient. So what do you think? Again, we evaluate preload. You see there's no problem with the preload. What about contractility? We are borderline. Cardiac index is 2. Global ejection fraction is 19. What about systemic afterload, systemic vascular resistance? 1800, slightly lower than the normal. But the extravascular lung water is increased, 15 now, and the permeability index is 4.5. So I would be concerned about the increased extravascular lung water for this patient, and probably you would need to diurese him a little bit and keep him intubated. Once the extravascular lung water is normalized, at that time you can look at the other parameters, and if everything is fine, you can probably extubate the patient. Of course, the higher permeability index indicates that this patient may have increased permeability or SIRS induced by the IPIC. Going to the next case, we have a sickler with acute chest syndrome, status post exchange transfusion. He did have acute kidney injury secondary to rhabdomyolysis. The nephrologist is insisting that he needs to give the patient more fluid. Mechanical ventilation showing stiff lungs with FiO2 requirement of 100% and PEEP of 10 centimeter of water. So in order to make appropriate decision, you decided that you want to do a transpulmonary thermodilution. Before you did that, you looked at the IVC diameter, and by ultrasound you find that the diameter is more than 2 centimeters. That's why, in order to get more data, you decided to put transpulmonary thermodilution device. And the device showed the following. So again, we evaluate the preload. Preload is evaluated by the global end diastolic index, which is clearly higher than 700 here. The stroke volume variation is 7%, and the stroke volume index is 66. We do not have preload problem. Take a look on the CVP, also 10. So we can answer the nephrologist based on the preload here by saying that we don't think that this patient needs any further fluid. However, if we take a look on the contractility, the global ejection fraction is 26%, and the cardiac index is very high, 9. So we have an increased stroke volume index, we have an increased cardiac index. Look at the heart rate, 136. And the afterload, this patient's systemic vascular resistance index is very low, 583. So clearly we have disruptive shock syndrome with decreased SVR and increased cardiac output. Now, if you take a look on the extravascular lung water, you would say, well, this is too high, 23, and the permeability index is above 3, indicating that this patient may be he has pulmonary edema. It could be or it is likely non-cardiogenic. The mean arterial pressure is 75. So this patient can tolerate, if you want to take off some fluid for this patient, I think it can be tolerated. But at the same time, don't forget that this patient has distributive syndrome where the SVR is low for him. So the next step was to give this patient diuretics. And FiO2 was down to 60% from 100%. Urine output improved, patient diuresed. The CK is declining, and the urea creatinine plateaued. The numbers that you see, the global end diastolic index is slightly low, but stroke volume variation is 8, stroke volume index fine. I don't think he has any preload here. We, in terms of the contractility, global ejection fraction improved 27%, cardiac index decreased slightly from value of 9, and SVR improved. His mean arterial pressure is 76, extravascular lung water improved, and the permeability index is 4.9, indicating that this patient is having non-cardiogenic pulmonary edema. Then the last case that we have is a patient who is 68, who is a 68-year-old, end-stage kidney disease, a septic shock secondary to gram-positive coccidioids. Now he's in the ICU after cardiac arrest, and you put the transpulmonary thermodilution device, and the patient is already on norepinephrine 0.8. So let's analyze the data. Preload more than 700 for JD, global end-diastolic index, acceptable stroke volume variation, decreased stroke volume index. So two parameters are not consistent with preload. However, the stroke volume index is decreased. Now contractility, look at the global ejection fraction, very low. And the cardiac index is low, along with stroke volume index being low. So we have major contractility issue. The SVR is increased, meaning that we have an autonomous system response compensating for the shock that this patient is in. So what are you going to do with this patient? He's on norepinephrine of 0.8. Clearly, with this contractility issue and the elevated SVR, this patient may benefit from an inotropic agent. And with the increased SVR and the blood pressure being, you probably saw that the mean arterial pressure was 90 or 99. So adding dopamine would be very appropriate. So we added dopamine for this patient. Dopamine is beta-1 stimulator. It's going to increase the heart rate. It's going to increase the cardiac index. You can see global ejection fraction improved. Stroke volume index improved slightly. At the same time, it's beta-2 stimulator, and it would decrease the stroke volume, the systemic vascular resistance, and it would decrease the mean arterial pressure. No changes, as you see here, on the extravascular lung water, and the permeability index is 1.2. CVB is 11. The global end-diastolic still elevated. This patient doesn't have major preload issues. So on day 2, the preload numbers, parameters are still acceptable. Global end-diastolic index more than 1,000. Stroke volume variation 14, and stroke volume index 37. Contractility is better. You can see cardiac index is better. The global ejection fraction improved. Stroke volume is acceptable. The afterload or the systemic vascular resistance is improved. Now it is lower than 1900. Remember, it was in 3000 or more. Now we have decreased SVR. What happened to the extravascular lung water index? Acceptable, less than 10. The permeability index is acceptable. Look at the mean arterial pressure, it's 57. So what are you going to do for this patient? Contractility is better. No issues with preload. Extravascular lung water is fine. Permeability is decreased. However, this patient is hypotensive and has low SVR. So clearly, you're going to add another inotropic agent and vasopressor. And the agent that combines these together is epinephrine. So with epinephrine, you can improve the mean arterial pressure, you can improve the systemic vascular resistance, you can improve the cardiac index at the same time without affecting, of course, the reload. This patient stabilized and is discharged from the unit. And with this, I would like to see if you have any questions, and we will proceed to the Swan-Ganz workshop after this. Thank you.